So, dear colleagues, Chairman, thank you for this opportunity to present this afternoon on the role of imaging in left main. This has been a fantastic EBC despite the challenges that COVID has thrown up. So I've been tasked with looking at whether we should be using imaging for every left main intervention. My name is Tom Johnson, a consultant cardiologist working in the UK in Bristol. These are my disclosures, and I would like to thank Tim Kinnaird, a colleague from Cardiff, who has kindly shared some slides that have been adapted for this presentation from our work done from the British Cardiovascular Interventional Society audit dataset. So I think the first thing to acknowledge is that with regards to imaging in PCI, we seem to have fairly polarized camps of practitioners. So on the one hand, we have those that would say that they have either's eyes. They've done enough imaging to know how their interventions proceed, and therefore they don't need to be using imaging. And then interestingly, in left main, we then have another camp who say, I always use intervention. There is no way I could go without. And so, you have to then question, when we have such diametrically opposed opinion, where the truth really lies. If we firstly look at the I always camp, well, the UK data would suggest that not everyone gets imaging for left main. And although we've seen an increment from 2007 to 2014, from 30% of cases to 50% of cases being imaged, clearly not everyone is. Now that might be still that we have operators that do always and operators that don't, but I think really there's probably a balance reality. If we then consider the camp of those that don't image, then the statements that we often hear in support of this are, well, I've learned from experience. I've done so many of these that actually I now know how my devices behave. Or perhaps there's a justification that through adhering to the EBC mantra of POT, final kissing balloon, repot, that actually if doing that, then there isn't really the need to consider further optimization by imaging. And then often we hear that imaging incurs unnecessary cost financially and cost of time. And then also that actually my outcomes are good. Why do I need to be enhancing it further? Imaging is perhaps for other operators, lesser volume or lesser experienced operators. And so often I think these are the statements that we hear in justification for not using imaging in left main. Actually, if we turn to the reality, even if we look at the most contemporary data, so Excel 5-year data, now here presented 3-year outcomes in terms of death, stroke, MI, and ischemia-driven revascularization. And this is a really nice subgroup analysis by David Kanzari, looking at just the PCI population, those that had provisional 1 stent against those that had planned 2 stent with the dotted line. And we see that clearly the more complex intervention carries a greater hazard. And I would really argue that, here, even where imaging was used in over 3/4 of patients, can we really suggest that a 30% event rate at 3 years is a good outcome? And I would suggest not. This is not adequate. Now, the response to that would be, well, we've moved on, in fact, from Excel, and we now have DK crush. That's the answer. We hear everyone saying DK crush must be the method that we use. And obviously that does stem from the very powerful data from Chen demonstrating this benefit of the role of DK crush over a provisional in the DK crush study that has already been expanded upon during this year's meeting. But I think then if we consider clear comparison, unfortunately not all endpoints are directly comparable, but if we look at the 3-year outcome of the XL2 stent data that I've shown from Kanzari and the DK Crush 5 cohort, we see that there is an excess of all-cause death in XL. Myocardial infarction, it's reported all versus target vessel in the DK Crush 5 cohorts, but we see a striking difference in terms of myocardial infarction. Target lesion revasc is defined either as ischemia-driven revasc of the left main in XL or TLR in DK crush. And again, there's a striking difference there. And there's at least a halving of definite stent thrombosis reported by DK Crush 5. So perhaps maybe, DK Crush is something we should be considering more in the left main stem. But the only caveat there, again, would be looking at the original inclusion of operator or inclusion of sites for this study. Operators needed to be performing over 300 PCI a year for the last 5 years, and they needed to be undertaking 20 left main PCI per year. And interestingly, when we look at how they went about their interventions, imaging didn't really play a major role. So pre-procedural IVUS was undertaken in just under a third of patients, and overall IVUS was adopted in about 40% of cases. So maybe it is procedural expertise, volume, that defines this. Now, reverting to the UK data set, which I'm more comfortable in kind of justifying, then this is the data from Tim's work with the BCIS audit. And we see that, interestingly, in terms of use of imaging, there are differences according to operator case volume, with a gradual increment with increasing case volume until we reach the highest volume operator group, where interestingly we see this drop off again in imaging usage, perhaps again indicating that IVUS eyes exist. And we see across the span of the 8 years of assessment that IVUS is by far and away the most commonly used modality, with a slight creep of usage of OCT over the last 4 or 5 years. Now, looking specifically at operator volume, Tim and Adrian and others have published really nice work again this year, looking at this BCIS data set. And we see that the vast majority of UK operators are undertaking less than 10 left mains per year. And in fact, if we look at the quartiles, quartile 1 has a median case volume of 2 left main, quartile 2, 5 left main, up to 21 median cases undertaken in the highest quartile. And so if we reflect back on the DK Crush experience, that would suggest that really there are only 11 operators in the UK that could have participated in the DK Crush study. But importantly, when we consider operator volume against the outcome, here you see quite clearly that the highest volume operators have substantially improved outcome. Here, the cumulative incidence of events just over 5% versus 12% in the cohorts with less experience. And that's true for in-hospital Mackie. We see this gradient from lowest volume to highest volume, this decrement in Mackie rate, mortality in hospital. 12-month mortality, really the only difference is seen in the highest volume operators. Peri-procedural MI, procedural complication rates, we all see reduce with experience. And so there does clearly seem to be some benefit in terms of increasing experience. Maybe though, if the majority have lesser experience, imaging could be used to overcome this volume deficit. So if we return to the BCIS imaging data sets, then we see interesting associations in multivariable analysis. So interestingly, imaging was adopted more often in patients undertaken via the radial access, possibly indicating a younger cohort or those more willing to adopt contemporary practice, being those that will engage in imaging. We see that the more complex bifurcation anatomy made it more likely that imaging was used. A stable presentation, and again, this acknowledges that the more kind of complex, the sicker patients maybe aren't appropriate for imaging. It's an interesting observation about trainees being the first operator. We think that most likely reflects the fact that these are procedures being undertaken in higher volume university or tertiary centres. And yet we see that the sicker patients, again, those who've had previous intervention with lower ejection fraction or more complex disease, are again less likely to have imaging use, where perhaps imaging would be more useful. And then if we look at the outcomes from the use of imaging, then again we see this reduction in complication rate. Importantly, no difference in acute kidney injury as a consequence, although OCT was used in a very small minority of cases. And we see these stark benefits to outcome in terms of in-hospital death, Mackie, mortality at 30 days and 12 months. And this is nicely demonstrated in this Kaplan-Meier plot, showing an absolute reduction of 4% in mortality at 1 year, a 30% plus reduction with the role of imaging against NOT in unprotected left main stem PCI. How does this compare? UK data against other centres. So if we look at certainly European data from the Swedish SCAR registry, very similar outcomes. Jose is going to talk to us about the role of IVUS in relation to left main. And then we see more global studies from Southeast Asia, all demonstrating this clear benefit of the role of imaging against angio-guided intervention in this complex group of patients. So in conclusion, should we be using imaging for every left main? Well, kind of West Country saying would be yeah, but no, but. Well, imaging clearly is associated with improved patient outcome. Although I think it's important to concede that not all left main PCI can be image guided, I would argue that most cases should be image optimized. So the sicker patient, we may not be able to use imaging up front, but we certainly should be adopting imaging towards the end of a procedure to confirm an excellent result. And I'd actually turn this back to the panel with another question, which is an important one, I think, from the data I've shown, which is, should all PCI operators undertake left main PCI? So we've seen clearly this relationship between operator volume and outcome, and it does make you question whether it should be an increment in imaging or maybe more guided selection of operator for procedure that we need to consider to improve outcomes for our patients. I thank you for your attention.